Hello, I'm Paul Wakim. I am Chief of the Biostatistics and Clinical Epidemiology Service at the NIH Clinical Center. And this is part 3 on randomization in clinical trials. And in this part, we're going to continue our discussion about how to randomize. And if you remember, we talked about the first two methods that are listed here in part 2. And in part 3, we're going to talk about stratified, cluster, and adaptive randomization. So in stratified randomization, a stratification variable or factor is an important baseline characteristic that may influence or predict the participant outcomes. And this is going to get a little bit clearer as we go. So strata, so I'm giving you a little bit of terminology under the stratification. So stratification variable would be like sex. The strata are the levels of the stratification variables. So it would be males and females, 2 strata, 2 levels. So example of stratification variables, you could have site in multi-site clinical trials. That would be a site, could be a stratification variable. Sex, age group, severity of disease. And in stratified randomization, it's actually very simple. The randomization is performed separately within each stratum to achieve treatment assignment balance within each stratum. So think about it, running the trial for the separately for the different strata. So again, how do you implement stratified randomization? So let's say you have a block randomization, a block size of 4 that we talked in part 2 with a stratification by site. So the clinical center is the stratification variable. The different sites are the different levels of the stratification variable. So it's actually pretty simple. You think of running a trial at every site separately, and you do your block randomization as if each site was a separate trial. So you run the blocks, the random blocks of size 4 for site 1, a completely different separate series of blocks for site 2, and a completely different series of block of size 4 for site 3. So it's nothing really new. The only thing new is that you do it separately for the different stratification levels. So now let's say we do stratification by sex. How do we run this? Well, that's what we're going to do. So this is permuted block randomization, block size of 4, stratified by sex. So we have the same 32 participants that we had before, but now what we're going to do is we're just going to separate the women from the men. And separate is all virtual, where we're not separating anything. This is only virtually in terms of programming. We separate the women from the men, and we basically run as if we were running 2 separate trials. So the women are going to get their block randomly selected and assignment, and the men are going to get their blocks randomly selected and assigned. So basically, we do what we did before, except on 2 separate parallel tracks. And so the assignment, it happens to be like this. But now look at what has happened. We have the same number of people in treatment A as in treatment B, which is what we had in block randomization. But now what we also have is the same number of women in treatment A as in treatment B, and the same number of men in treatment A as in treatment B. So now we have taken care of both problems. We have the same numbers in A and B, and we have a balance of women and men in both treatments. And we solved now both problems that we had with simple randomization. So the pros is that within each stratum, male or female, there is balance between the treatment groups. There are as many men in treatment A as in treatment B, and as many women in treatment A as in treatment B. But please don't confuse with saying that there is many men as women in treatment A and as many men as women in treatment B. We don't control how many men and women consented and are ready to be randomized. So we can't put as many men as women in treatment A and as many men as women in treatment B. We can't do that. We don't control that. What we can control is to balance between the women between treatment A and B and the men between treatment A and B. So that statement is not correct. One of the disadvantages of stratified randomization is the number of cells. People sometimes go wild with the stratified randomization, but the number of cells can increase very rapidly with just a few stratification factors. Let me give you an example. So let's say you're running a trial and you have 4 stratification factors, which is really, look at what they are. They're not really far-fetched. You have a multi-site clinical trials. Let's say you have 3 sites. So you definitely want to stratify by site. You have sexes, 2 levels, 2 sexes. So you want to stratify by sex because that may be different. For men and women, the intervention the efficacy may be different for men and women. And let's say you think age has something to do with the outcome. So you want to stratify with age, and you just pick 3 age groups. Not a lot. And you want to stratify by severity of disease. And just the minimum is, low severity and high severity. So it sounds like, it's pretty decent. But look what happens. How many cells, and I put quote cells, do you have? 36. Now remember I had men and women, and you're running it separately. Well, now you have 36 tracks running parallel and separately. And of course, it's okay because computer programs are doing all this. From a technical point of view, that's not an issue. The issue is, do you have enough people in each one of those cells? And if you don't, that may cause a problem. So remember, randomization is conducted separately within each cell. So if we put all these pieces together, I'm just showing you an example just to tell you that this is real. People are using these designs. It's not just concept and theory. This is a trial, the clinical efficacy and safety of a novel tetravalent dengue vaccine in healthy children in Asia, a phase 3 randomized observer-masked placebo-controlled trial. And in this trial, healthy children aged 2 to 14 years randomly assigned 2 to 1 to dengue vaccine or placebo. So 2/3 went to the dengue vaccine and 1/3 went to the placebo via permuted blocks of 6, stratified by age and site. So again, this is just to illustrate that, this is real stuff. People are using these methods. Okay, so now we did the stratified randomization. Let's talk about cluster randomization. There's nothing very deep about cluster randomization. The only difference, cluster randomization, instead of randomizing a person, you randomize a group. For example, they call it social units as an example, a cluster of individuals. So a cluster randomization trial is one in which intact social units or clusters of individuals, rather than individuals themselves, are randomized to different intervention groups. What are examples of clusters? You can have a household where you randomize the whole household, not the individuals inside the household. The whole household is randomized to different groups. The neighborhood, a classroom, a school, a work site, a physician, a clinic, or a hospital. These are clusters of people and the whole cluster gets randomized. Now here's a little bit the trick with the cluster randomization. It's a little bit tricky because the outcome measure is usually at the participant level, but the unit is being randomized. So there is a little bit of, not a disconnection, but a little bit, they're off. And we're going to mention very briefly about that. So here's an example, a real example of cluster randomization. It's the ring vaccination trial, a novel cluster randomized control trial um, designed to evaluate vaccine efficacy and effectiveness during outbreaks with special reference to Ebola. So in this case, and I thought it's genius, what they once they recognized a person who's newly diagnosed with the Ebola virus disease, they form a ring around that person, and that becomes the cluster. And then they randomize the whole cluster, those who are eligible within the cluster, 1-to-1 to either immediate intervention or a 21 delay vaccination. So the cluster is this ring around the person who was newly diagnosed with the Ebola virus. And then if you look at the title, it talks about efficacy and effectiveness. The efficacy, they compared the hazard ratio in those enrolled in the study. So those in the cluster that were eligible and enrolled in the study, and the effectiveness is all of the people in the cluster, those who were enrolled and not, they compare those in terms of the hazard ratio. So why do we cluster randomize instead of just doing a regular individual randomization? Well, it could be, individual randomization may be impractical or even impossible. Think, for example, about a teaching method. You can't, maybe within a school you could have different classrooms having different teaching methods, but you can't have within a class different teaching methods. So that's just impossible. It could be also impractical. It complicates things. If you do it within the cluster, you randomize within the cluster. Cluster randomization prevents contamination. So think of a physician, for example. A physician, all the patients that see that physician can be a cluster. But let's say you don't use them as cluster, you randomize them individually. So the physician is basically saying, oh, this patient is part of treatment A, so I'm going to treat that person as A, and this patient is treatment B, so and therefore there could be some, we call it bleeding of the treatments from A to B and from B to A. So, or contamination. And the cluster randomization prevents that because it's randomizing the whole cluster. And it may be just convenience or cheaper to cluster randomize. So how to implement cluster randomization? It's basically the same thing. It's the same as individual randomization, except that the unit of randomization is the cluster. So all the methods we talked about with individual randomization can apply to cluster randomization. Except that the only difference is there's a matching of clusters before randomization. So let's say, for example, we're gonna randomize hospitals. So a hospital is the cluster, and we have a list of hospitals that agree to participate in this trial. Okay, so we have a list of hospitals, and they're going to be randomized. Hospitals are going to be randomized. Well, you may want to match the hospitals in terms of size, for example. So you get the biggest two hospitals up there, and then you randomize the two biggest hospitals in A or B. And then you get the next two in terms of size, and you randomize. So you're basically matching them in terms of size in this example of hospitals. So again, sort of a little bit of a repeat here, but cluster randomization, the pros, it's more feasible in some cases, minimizes contamination, more convenient, and cheaper. The cons are, it's the unit of analysis. It's a little bit what I was talking a minute ago, is you're randomizing clusters, but in some cases, you analyze individuals. The unit of analysis should be the unit of randomization. But that's not really what you're doing. You're analyzing individuals. So there is a little bit of, it's a little bit off, and some things need to be done to take care of that sort of in alignment or unalignment or something like that. The number of participants in each cluster can be a problem. So if you have a hospital or two hospitals that are huge compared to the others, their results may dominate the results of all the others. So the number of participants in each cluster, I mean, it's not a question of randomization. It's not a question that, yeah, you have as many you have the two biggest hospital in A, one in A and one in B. That's fine. But these two hospitals may dominate the results of all the others that come after it. And then you have the intra-class or intra-cluster correlation. And that's very important to take into account the effect of an intra-class correlation. What is the intra-class correlation? Basically, it says that within a cluster, there is similarity. They are all within that cluster. They're not from another cluster. So therefore, there is a correlation among those in that cluster that is not, they are independent or they're not correlated with another cluster, but within that cluster, there is some correlation. They are under the same physician. So obviously, a good physician, there is some correlation. A bad physician, there's some correlation. So that really needs to be taken into account, the ICC, what's called the ICC. So far we have talked about fixed allocation algorithm. What does that mean? It's not fixed versus random. Fixed allocation algorithm means that the randomization scheme is decided up front and this does not change. So you can have the whole string of assignments before even you start the trial. That's fixed and it doesn't change. That's the way it's going to be, and that you do the whole trial with that scheme, that sequence of assignments. That's fixed allocation algorithm. Versus adaptive methods or dynamic allocation. And we're going to talk about that, and that's where the chances of assignment change as you are enrolling. And that's what's called adaptive or dynamic. So, and there are at least two, but I'm going to talk about two adaptive randomization. Minimization was a covariate adaptive allocation. Basically, you change the allocation probabilities. So you're tweaking those probabilities. You know, we said 1/2 to A, 1/2 to B. But here, after you see where, like the next men, the men went A versus B, or the woman went to A versus B, after you see that, you change the probability. So it's not really 1/2, 1/2. You tweak them so that they kind of fix the balance. Not in a deterministic way, but in a probabilistic way. So you change the allocation probabilities to minimize any imbalances that have occurred by chance with respect to important baseline factors. So you're observing what's going on as the trial is going, and you keep tweaking those probabilities to keep the balance. And then there are the response adaptive allocation. Now remember, the first one is on baseline factors. So sex, age, severity of disease, etc., socioeconomic status, etc., baseline factors. In the response adaptive allocation, you are tweaking the probabilities based on their response, the outcome of the trial. So responses of participants enrolled to date change the allocation probability of the next assignment. So how do you implement adaptive randomization? It's actually pretty complex. You can imagine there's this dynamic thing that goes on, and you really need expertise and software. For minimization, that's the first one. Baseline characteristics need to be quickly measured and entered into the database. So what this is talking about is saying basically, okay, if you're going to be tweaking those probabilities, you have to keep track and as fast as possible. So, okay, what was the next assignment? Who was it? Where did they go? Let's put that in the database so we can change the probabilities of assignment as fast as possible. With response adaptive assessments need to be quickly measured and entered into database. The first one is the baseline characteristics. You randomize, you look at their baseline characteristics, you enter that in the database. But in response adaptive, you have to wait until their outcome, their primary outcome, is measured, is assessed and measured, and then enter it into the database, and then change the probabilities. So that needs to be done quickly for response adaptive. So what are the pros? In minimization, it may be more efficient than stratified randomization when sample size is small relative to the number of stratification factors or cells. And these things are changing. I mean, the people are understanding minimization better, and so these statements, you have to take these statements a little bit with not too definitive, because things are changing. The research on adaptive randomization is really still going on, and it does change. Response adaptive allocation, it maximizes the number of participants on the more promising treatment, because you can say, okay, when I see that this treatment is doing well, people are responding well to this treatment, I want to increase the probability of sending people to that treatment, which is better. So that's the advantage. What are the disadvantages? The disadvantages of adaptive randomization. The implementation and the statistical analysis are more complex. And there are these agencies, they have some concerns. I don't want to sound too definitive about them because, again, like I said, research is changing. But there is some concern about adaptive randomization, particularly the response adaptive randomization. And that's it for this segment. And in summary, in stratified randomization is performed separately within each group to achieve treatment assignment balance within each group. Cluster randomization is when groups of units or individuals are entirely, as opposed to individually, randomized to the different study treatments. And in adaptive randomization, allocation probabilities for the next treatment assignment are changed after each executed treatment assignment. And my questions to you is, what is the difference between fixed and dynamic allocation? And what is the main benefit of stratified randomization? Thanks for watching.